Hi, this is Jason Switchka. Just checking my mic to see if you can hear me.
We can hear you loud and clear, Jason. Thank you.
All right, you bet. I'll put myself back on mute.
So thank you so much for everyone who's called in. We see we have a nice crowd that is joining here. We will start in approximately 3 minutes. Feel free to use the chat button if you have any technical challenges or issues. If you can't get through that way, you're welcome to email Margaret or Cassidy.
Hi, everyone. I'm seeing in the chat that some people are hearing a lot of rustling or noise in the background. Just remember, if you're not speaking or asking a question or presenting, to put yourself on mute to kind of minimize that. And Mark, I'm going to go ahead and pass the controls over to you.
Thank you so much. So thank you everybody for joining. We have a wonderful group of individuals on today, and it's great to see some familiar faces. I know that we are all in a crazy time here with the epidemic and pandemic, and hopefully this call will provide an opportunity to see each other, hear each other's voices, and continue not with normalcy, but with some of the activities that were going on before this event. It is going to be recorded, so if there are members of your team that can access this, please feel free to share. And I really just want to give a shout out to the EIIC group, to Margaret and Cassidy for helping put this together. And I appreciate that many of you may be like me and have kids jumping around in the background and things. So if you do, we might hear you and just remind you to mute if you're not muted. So in terms of the webinar, please, an effort to reduce background noise. There's a couple people that I hear some feedback coming from. If you can just keep your mic muted, and then we can open up the mics at the end. If you are willing to show your head and your video, that would be appreciated. I think it's nice, particularly right now, to see each other's familiar faces, since many of us have not seen people in a bit. And please do not put your phone on hold. That leads to actually some background music in many of our departments. Thank you again for joining the webinar, and really sorry, I'm just a little delay here. So as many of you were lucky enough for me to have the opportunity to work with. I was lucky to have the opportunity to work with many of you, sorry, rephrase that, during the PECC Collaborative, the Pre-Hospital Pediatric Emergency Care Coordinator Collaborative, and we've now moved that to community of practice, and we're really excited to have individuals from some of the other EIIC activities and hear the story of a couple of our collaborators in that effort today. We had last heard really an update from our constituents going back to the EMSC national meeting last summer, and similar to the facility recognition and other collaboratives within EMSC, we know that there's much that goes on after the collaborative locally, and we're excited to use the community of practice as a way to hopefully maintain and sustain some engagement. We'd like to acknowledge HRSA and the Maternal Child Health Bureau and EMSC, EIIC for their support of this work as a part of the grant listed there, and the information and content that are going to be presented by myself as well as the wonderful presenters today are not the official position or policy of HRSA, HHS, or the US government. So our agenda for today, our agenda for today is to hear from 3 of our states from the collaborative. The collaborative occurred over a 6-month period, and we are very fortunate to have 3 states that are willing to share an update. We'll hear from Pennsylvania, from Dwayne Spencer and Leonard Brown, from New Mexico, from Catherine Schaefer, Robert Sapien, as well as Sarah Dakin, and from Wisconsin, from Erica Kane and Joel Deutsch. The names on the left may be familiar to many of you as the leads of the PECC efforts in that state. And the names on the right, I'm very thrilled to report, are frontline PECCs. So these are individuals that actually are PECCs in these 3 states to talk about some of their experiences. So our hope for this session today is that the team leads, Dwayne, Catherine, and Erica, will share their experiences with the implementation of PECCs as well as challenges and lessons learned. And then really exciting to hear from 3 frontline PECCs, both their successes and challenges, Leonard, Sarah, and Joel, and really appreciate again everyone's willingness to take time during this busy period. So in terms of the performance measure 2, just to level set for people, this is really what the PECC Collaborative was intended to help potentiate. So we had 9 states that worked together intensively and had some funding during that period of time. But really our goal is that the percentage of EMS agencies in the state or territory that have a designated individual or group of individuals coordinating pediatric emergency care will increase, and that the goals are really by 2020 that 30%, 2023 60%, and then 2026 90% of agencies will have an individual or group of individuals. Looking at the sorry, I am like the worst at delay here. So looking at the PECC Learning Collaborative, we saw a very rapid uptick in the first few months, and then we're thrilled to see that after the close of the collaborative, when we did our final calculations, that we exceeded our goal of 369. Each of our improvement collaborative states set their own goals, and we were able to go beyond that. And with the beginning of the community of practice, which is the last time we did do a measurement, we were at 525. With the EMS survey that is currently going on, we'll be able to get some additional real-world information. So the collaborative, as I mentioned, involved 9 states. We're fortunate to have 3 of those 9 presenting today, and we've heard in prior sessions from some of the other states. If you are interested in reaching out to any of these states or learning more, the EIIC website has contact information as well as resources from each of the states, as well as the websites that many of the states have created. The community of practice, and just to frame what this concept is, and this is really an open community of practice. So some community of practices require attendance at every session and have a very set membership. We have taken more of an open membership model where any individuals that have a shared goal of improving pre-hospital care through the implementation of emergency care coordinators would be considered members of our community. And the practice, meaning what we're going to do together in this webinar and hopefully virtually by interacting over email and using the resources that have been created, as well as other assets of EIC, to go through learning from and with each other, using not only these meetings, but email, phone, online interactions, and as well as a discussion of even things like office hours to have more of a local discussion or one-on-one discussion. We feel that by sharing best practices, experiences, and stories, tools, and the ways of addressing challenges in implementing a PEC, that through this community practice, we'll be able to more rapidly implement PECs through that shared learning and achieve that goal by 2026. So as I mentioned, all of the EIC learning collaboratives that have been conducted, and those often involve a set of people applying to participate, grow into what we term
1 4 5 0 9.
And this community of practice
is not available. At the tone, please record your message. When you've finished recording, you may hang up or...
Thank you. So as you see here with the graphic, the concept would be the community practice would be an even larger group, which I can see that we have a lot of people on the call today. So we're hitting that goal, and that through this community practice, we can begin to create really the best of breed content that would lead to national spread and that goal of 90% by 2026. So our objectives for today are I hope, fairly achievable. It's going to be to summarize the experiences of these 3 state leads as well as their frontline PECs, to hear from them strategies that they use to address challenges in implementing and sustaining PECs, because we recognized in the collaborative that the implementation was a challenge, but leading to sustained change may even be more challenging in many agencies with turnover and changes in leadership. And I think right now is a great example with changes in priority with a national epidemic. We're going to identify resources and best practices to support implementing and sustaining PECs. And I will say if there are gaps in those, we'd ask people just to help us understand those gaps so we can work through EIC to support creating those. So our first speaker is going to be Dwayne Spencer from Pennsylvania. So Dwayne is a very passionate pre-hospital provider, and currently has transitioned to the lead for the Children program, where he supports state partners. He was the lead of Pennsylvania's EMSC Pre-Hospital Pediatric Emergency Care Coordinator Collaborative, which he's going to be discussing today. He's also served as Pennsylvania's Family Advisory Network representative, so really has touch points in many aspects of the EMSC landscape. And he received a bachelor's in EMS from Drexel University, and 40 years of patient care experience in both ground, critical care, and aeromedical transport. He has held numerous positions involving leadership, including EMS of a large standalone EMS agency and being the director of a university-based agency. So Dwayne has also served as an educator and has led many national and local courses and participated in many ongoing initiatives. I'd like to really just thank Dwayne and the other speakers again for taking the time today, and let's move on, and please share the... Oh, I will introduce Leonard as well now. I'm sorry, Leonard. So Lenny Brown, and thank you, Leonard, in advance for joining us. It's really exciting to have some frontline PECs, and we recognize that it may be intimidating to see the large number of people, but smiling and pediatric heart, so pretty friendly people. So Leonard is a pediatric emergency care coordinator with Good Fellowship Ambulance Club of Westchester, Pennsylvania, and Royersford Fire Department in Royersford, Pennsylvania. He was a PEC representative on the PEC project when that was ongoing, and now has been an end user and individual responsible for pediatric readiness in his agency. He's been involved in EMS for 16 years as an EMT and became a paramedic approximately 4 years ago. And he's presently a shift lieutenant with Good Fellowship and an EMS supervisor and public information officer with Royersford. He's married, has 2 children, ages 8 months and 5 years. Dwayne will be presenting on Lenny's behalf, I believe, because he may have children in the room there. So thank you.
Great, thank you for those intros. Dwayne, I'm gonna get the controls over to you here. And for those who are joining, please remember to mute yourselves
Okay. Looks like I have control. Thank you, everybody, and thanks for attending today. On behalf of Lenny Brown, who is tied up because of some change priorities, I'm going to do my best to present his side of the story. But he certainly has a lot of his own individual efforts here. A little bit about PA. In 2017, just under 13 million people, but 21% of those being 18 years or younger statewide. A lot of our state counties in the state are considered rural, and 26% of the population is rural. So we have some highly concentrated areas of population. We did have some increase in our non-white Hispanic population over the course of the 8 years from 2010 to 2018. And we saw a somewhat equal distribution between rural and urban counties of households that have children. But if you look down and drill that down further, the urban counties had a higher number of children per household. So let's go back. And Margaret B went way past. I don't have control. There we go. So a little bit about our Learning Collaborative Steering Team, a larger than some of the other states' teams, but very diverse in representation. Myself as the fan rep and team leader, but our EMSC committee was represented. We had 3 PECCs on, that were currently active in that role on the committee. Are currently at the time EMS Children Project Manager, educators both at the regional EMS level and nursing level, pediatric emergency medicine representation from 2 of our pediatric hospitals in the state, and both our EMS council, advisory council, and our state bureau of EMS, along with our state medical director, were part of this steering committee. So a lot of good diversity in information, ideas, and feedback. Our roadmap was, but however, you know, it may be, it allowed us to keep on track by monitoring what we were doing, when we were doing it, and how we were moving forward. As the rest of the group started in the end of September, our Learning Collaborative Steering Committee in October had our first webinar on November 1st, and then continued to meet routinely throughout the course of the time frame via webinar and in-person meetings based on availability of the individuals. We introduced the process to our state EMS Advisory Council early in December, as well as to our Medical Advisory Committee in late November, to get engagement at those levels, at the physician level, at our Advisory Council level, where there's representation from various levels of stakeholders, from EMS agencies to healthcare institutions to other support agencies like the PECC, AHA, our Trauma Systems Foundation, things like that, to get them aware of it, get them involved, get feedback from them. And then we moved on to continuing to have meetings on what we need to do. And in early December, we surveyed our agencies to get some data based on the agencies that were participating, and resurveyed them in February with more specific data requests to ensure that we were meeting their needs and not just coming up with something that we felt was necessary but was implementable at the agency level. You know, by February we were meeting in person, and we were developing a lot of our deliverables. And by March, we were able to meet in person with our federal leadership and our team to talk about where we had our project was, what the deliverables were, and what our future state included. To meet our target of April 1st, where our website went live and our deliverables were, you know, printed and ready to be distributed.
For help, press *H.
So
Hi, Dwayne. I'm sorry. I'm going to go ahead and interrupt you. We're going to try to get a few people, because you have some really valuable information, and I want to make sure everybody hears it. Donald Watson, if you can hear me, please mute your line. We're hearing some background noise and some calling. Thank you. And just a real quick reminder, we have a lot of great information to cover in a short amount of time, and we definitely want to get this recorded for people who are out in the field right now. So definitely make sure you have your lines muted if you are not speaking. All right, thank you guys. And Dwayne, back to you.
No problem. Thank you. So to continue, we didn't meet our numbers target during the Learning Collaborative. We were only able to establish, confirm 32 new PECs during that implementation period of time. Since then, we've added an additional 48, and we've done that without a EMS program manager for much of that time frame. And now with the onset of some of the change in priorities, we had a little interruption in some of our efforts here in March, where we had 4 scheduled conferences, 3 being EMS regional conferences and another being our statewide trauma conference, where we're going to engage with people. So we realize our numbers going to lag a little, but our effort's still there, and we just have to reschedule. So a little bit about our strategy. We modified our PDS cycle to make sure we stayed on track and maintain a focus. And we took that PDS cycle and broke it up into 5 categories of engagement, needs and capabilities, resources, dissemination and education, and then support and maintain. And we initiated that over the initial target group, but now we're utilizing it in our phase 2 for 2020 to open the enrollment statewide and engage it across all of our over 1,200 EMS agencies. Our phase 3 will look at how the challenge services or special circumstances, those smaller or, on the other hand, very large services that might not be able to just throw a name or throw an effort into it, and it has to come with other complexities involved, working with them more individually in order to get them on board. And then phase 4 with our target statewide of 2022 being 100%, working to establish that.
Sorry, one more interruption. Margot, can you please mute your line, please? Thank you.
The idea, though, is to maintain focus on our challenge services after learning about our successes and challenges through the open enrollment. And that's where we are right now, with trying to identify where people can and cannot implement a PECC because of their individual agency or regional needs. So a little bit about our deliverables. Common to a lot of our other colleagues in the Learning Collaborative, we came up with one-pagers. On our hand, we came up with several to address some of the different components of the PECC, and looking at whether, it was what is a pre-hospital pediatric emergency care coordinator versus what models they could utilize. In Pennsylvania, established 3 models: the agency, community, and regional model, to best fit what the area could support, and also what the role of a PECC was, particularly so that we talked about, is it a job or is it an effort? And we wanted to give them an idea what the role of a PECC was. So we broke that down into 4 pillars of where a PECC could function in, them being education and training, quality improvement, community engagement, preparedness, and clinical care. And within those pillars, there's objectives that support each of the pillars that the PECC can pull from and focus on a smaller, more manageable component, and address that, one at a time, so they don't feel overwhelmed with trying to implement too many things at once and not really do a good job of any. Be successful at one before you move on to the next year. Some other deliverables were a postcard with information, just so that we could hand that out and people had it in hand. And we also came up with a reward for the individual PECCs being a challenge coin, which are numbered, and the first 500 PECCs will receive a challenge coin, and the EMS agency receive a certificate, recognizing that they've participated, they're engaged, and they're part of a program that's statewide. And finally, what came with a lot more effort than was initially identified, we established a website to support the Pediatric Emergency Care Coordinator, both on a public end side of it, where it's freely accessible to anyone on the internet, and talks about what is a PECC and how to get more information, as well as a private side where it's a members only, where people who are PECCs or medical directors for the agency or part of our support team can access information that we want to be able to share with them. And once they're registered, we can push information out to them via email as well, because they have their contact information, and we can engage them a little bit more one-to-many versus just globally across the internet and cyberspace. Pennsylvania's had the Pediatric the Pediatric Voluntary Recognition Program in place for several years now, and it has 5 different levels based on the agency's ability to participate, from basic equipment to up it to the expert, where they have all the other levels plus child passenger safety technicians. And we decided and voted to include the requirement for a PECC at the master and expert level, and initially that was to occur by January of this year. However, because of the lack of an EMSC coordinator in the program for a few months, we had to reinstitute that, and we're looking to apply that for July 1st. It's basically the person who's handling the program, our voluntary recognition program, will be the pediatric emergency care coordinator, and basically to assist the agency and be prepared for and responding to calls for service involving pediatric patients. We again list the pillars there to give them some broad strokes of guidelines, but it really allows them a lot of flexibility. Some of the feedback we got was that the PECC gives the program a cheerleader for the organization and someone to champion the cause. And I really want to focus on the word champion. This individual doesn't have to do all the work, but they are the person who's going to champion it, be a leader, be a facilitator, or whatever is needed to assist with implementing the product you're trying to put in place. And just the other component of feedback was it really helped refocus the program and upkeep the voluntary recognition program to ensure that they're holding the letter of the program. So it supported what we had already put in place with our VRP. Some of our top 2 challenges: engagement. We didn't have really good contact information. We were working off of contact information that was dated, and we have a lot of challenges with 1,200 services. We were able to overcome that a little, but it's an ongoing challenge, and will continue to be there with having to do it virtually. If we mailed everything out, businesses don't move too much, but we do have a moving, target of services coming and going because of the challenges in the industry, and that we work hand in hand with the State Bureau of EMS to maintain our records. And of course, timeline was short with the program, but now we can maintain some focus on some longer timelines and just make sure that we stay within our initial focus of our phasing. Our proud moments were our deliverables. We put a lot of product together in a short period of time, and they've been received very well. We got very good buy-in from both our State Bureau of EMS and from the EMS Advisory Council levels to support this. The state adding this as a component of bringing on board the PECC into the licensure function, so that we can identify every 3 years the service gets relicensed, so that we know we'll have a PECC information within the next 3 years. It'll be inclusive. However, names do change, emails do change, and we'll have some challenges there. But I think our information collection will be better off. And our top lessons learned was that we want to build on existing partnerships and not reinventing the wheel, unless, of course, it's missing, and it's a tough drive. So don't try and do everything over again. If it's working already, build on it. And stay slow and steady, not fast and furious. I think we felt we had to rush a lot with the time frame of the Learning Collaborative, but that's behind us, and now we've got a few years to get this going, and don't feel this has to all occur within a few months or a year. In fact, the larger states, larger number of services, it's going to take longer to implement and get people on board. And just the engagement might be slower, especially with what we're going through now. So, in speaking for Lenny, and Lenny apologizes, but he has some priorities that has prevented him from presenting. Lenny actually is an employee at 2 different organizations, the first being Good Fellowship Ambulance in Westchester, Chester County. Recently brought on as an ALS provider because they took over the ALS role from a local hospital-based provider. Then run over 6,000 calls a year. Their accommodation service, do a lot of volunteer hours, who help support the career staffing and putting the 2nd and 3rd and 4th ambulance on the road. He's a supervisor and a paramedic there, and he transitioned to the PECC role because of his prior role in another organization. That other organization is Royersford Fire Company. It is also a accommodation department. They're about 10 miles away from each other, 2 different counties. A little smaller service, but it's accommodation volunteer paid, mostly volunteer on the fire side, all paid on the EMS side. He's the assistant chief there as well as the PIO, and he became a PECC there and represented the PECC on our learning collaborative due to an unmet need in the organization. They discovered they needed somebody to help with pediatrics, and he was the guy that stepped up. I'm not going to tell Lenny's story because it's his words, but what he feels he does is he promotes pediatric awareness. He engages team members in the related activities, and he speaks about being the cheerleader for the effort. I think you'll see that here in a little bit, of what he means by that. He's using a lot of collaboration within and outside the organization, both in local, regional, and even a larger regional area, using colleagues and connections you have within your department or within your community. People believe he's key to promoting better care and relationships there, and he's constantly reprioritizing basically what his next steps are in the current situation. Is a case in point here where he's got to refocus on some larger aspects of his role and not just being the PECC. Some of the activities that Royersford and Good Fellowship have been part of are a lot of public safety, school education at all grade levels. Royersford is in the school, the high school and middle school are in their first due for a larger school district. They've done a lot of engagement hands-on with kids, and it engages the kids to the EMS side of it as well as EMS providers with kids. They've done a lot of staff preparedness and education, bringing on new equipment to better allow them to care for patients more safely or more efficiently. They've been part of a toy run, which again engages the EMS community back into the pediatric level, where numerous EMS agencies do a toy run each year to 2 pediatric hospitals, and they meet the kids. The kids meet the sick kids, and these are high acuity kids, meet the ambulance and EMS staff and really have a positive interaction between the two. And it starts breaking down barriers on both sides. And let's see if I can get this to work here. If not, Margaret, this is just a brief video of what Royersford did. They have a lot of community collaboration. They've got partners that help produce something like this. But this is a young child who was one of their patients who they wanted to bring back in and kind of reduce the stigma of the ambulance took me to the hospital and a lot of things that hurt or I didn't like took place, and just reintroduce her to the role and the people that were part of her care. Backward, there we go.
Here, I can try real quick tonight.
Yeah, if you would, please. I'm not hearing the sound, Margaret, so that's fine.
Okay, sorry about that.
That's fine.
I'm hearing sound, but it's playing out of my computer.
So the idea of the video was the patient was brought back into the firehouse and interacted with a lot of the people who were part of her transport to the hospital. But making engagement with Slapshot from the Reading Royals, one of the local sports areas for that region, as well as one of the Paw Patrol figures, allowed the child to feel more comfortable, more at home, and engage with the people that she might have seen had a part of it hurt or I didn't like it. And they made her a firefighter for a day. She got to ride the trucks. She engaged with a lot of the people there, both police, fire, and EMS. And it just was a really rewarding experience for everyone to see how she was able to, turn that I'm scared of everybody to, I'm open, and she would welcome them back into her life. I think it's very positive and a tremendous effort if you have the right collaborators available to you. So for them, it works well, and for others, it may as well. So two of our biggest challenges as a PECC is time and money. There's not a lot of time available, as Lenny's job roles demonstrate. He's got many, many hats, and there's not a lot of money dedicated to this. So how they can, distribute it, what's available to what they have, or they can get people to volunteer, or they can get outside collaborators to, support them, reduces some of the indirect costs from the agency. Some other tips for the role is keep it manageable. Like I said earlier, don't take off too big of a bite, and make projects fun and engaging for everybody who's participating. That's not just the kids that might be there, but the providers as well. During the video, everybody was having a good time. It wasn't work, it was fun, but it was a learning process. And 2 tips for how to get others involved is talk. Conversation leads to action. Talk to your colleagues, talk to people within your department, within your community. How can they help? What are some of their ideas, or what are some of their needs, and where they might be able to fit into your plans moving, downstream. Maybe not tomorrow, but next month or next year. And engage them, include those partners and participants who you think are on that edge of the box or even outside. You might not know you need them until you come up with an idea and go, hey, I talked to somebody about this. Let's re-engage them. They may become your next resource. And the biggest tip that I included for Lenny was never forget family. With all the workload we have as EMS providers, and all the different hats we wear, we got to be able to go back home and not take it home. Remember that the family is involved there, and keeping everything safe and engaged at home, that the work isn't taken over. I want to thank everybody, and certainly can take questions offline or through the chat box when we're done.
Great, thank you so much, Dwayne. I'm going to go ahead and gain control back from you. And next we have Robert Sapien, Catherine, and Sarah presenting. So Dr. Sapien is a tenured distinguished professor of emergency medicine and pediatrics at the University of New Mexico Health Science Center. He is the principal investigator for several projects, including the New Mexico EMS for Children and Child-Ready Regionalization of Care projects, and he serves as the Associate Dean for Admissions and Director of the Combined BA/MD degree program at the University of New Mexico School of Medicine. We have Catherine. She is a 2007 community health graduate with a passion for child passenger safety and injury prevention. After serving as a case reviewer for the New Mexico Child Fatality Review Program, she has worked with New Mexico EMS for Children since 2001 in various capacities with Dr. Sapien. With this duo, the EMS for Children program has grown for a successful EMS resource in New Mexico for pediatric education and injury prevention collaborations. She is happy to travel across New Mexico to coordinate pediatric-specific outreach in the form of mini conferences and skill trainings. She is a CPS instructor with Safer New Mexico Now, the current vice chair of NSEMSO Safe Transportation Committee, and serves as the state's EMSC liaison for the Trauma Process Improvement, University of New Mexico's EMS Consortium, and statewide EMS advisory committees. And lastly, we have Sarah. Sarah's passionate about pediatric emergency nursing and has more than 20 years of experience working at the Pediatric Emergency Department and only Level 1 trauma center in the state. She has held many roles with the department from bedside nurse leadership to educator. In each of her roles, she has been a champion of the pediatric patient. Sarah is currently both an ENPC and TNCC instructor with the ENA and volunteers as a content expert for educational projects when able. She's presented on a variety of pediatric emergency topics at both regional and national conferences, and most recently, Sarah has completed a study looking at the efficacy of telehealth education to support rural emergency nurses in pediatric care. With this ongoing project, Sarah offers both education and real-time support to rural emergency nurses to care for pediatric patients within the community. Education is offered remotely, keeping both the patient and the nurses within their community, and increases the nurses' confidence to provide patient-centered pediatric care. And Catherine, I'm going to go ahead and turn it over to you for controls, but I believe Robert is speaking first.
Yeah, and I'm not going to take long. I just want to recognize Catherine and Sarah for all the tremendous work they've done on this initiative. Catherine's done a tremendous job putting things together, and Sarah's done a terrific job just kind of responding to what we need and helping us get through all of this. So I'll turn it over to Catherine.
there, Catherine. Are you possibly on mute? Hey, Catherine, I can see you controlling, but we're not able to hear you right now. Okay. We can go ahead and move on to Sarah's portion. So,
Margaret, can you by chance unmute her from your end, maybe?
Yes. Let me see here real quick.
I'm unmuted.
Catherine? Yes, hello? We can hear you.
Oh, sorry about that. It's like I've tried everything to unmute myself.
Okay.
So thanks, Dr. Sapien. I appreciated that. Sarah and I do this job because we really do appreciate it, and I guess I will page back up. Now I'm having technical difficulties.
You can use your arrow keys on your keyboard as well. Sometimes that's easier. Okay, we'll just do it from our end then. We'll just do it from our end. Just let us know.
Sorry. So can you go back to that first slide, please?
Yeah.
My apologies.
There we go. No problem. And just let me know when you'd like me to advance.
No problem. Thank you. So New Mexico is a pretty big state. It's the 5th largest in the state in the United States by landmass. We have about 17 people per square mile, so just over 2.2 million across our state. Most of the population is centered in our Bernalillo County area, middle of our state, Albuquerque, where we have probably about 1 million people within a 3-county radius. So the rest of it, it's pretty rural. I like how Montana always says how many elk they have per mile versus how many people, but I don't have those kind of nifty statistics. The part of this grant really originated back with our regionalization of care program in 2012 when we started developing a community-centered approach to really making sure that we had all of our the community, the schools, EMS, and hospitals really ready to treat that pediatric patient. So part of that is making sure that we develop some strategies that we could use across all those different entities so that we had a way to evaluate and help people assess themselves so that they could really be the champions of their own pediatric preparedness. Next slide, please. With the PECC collaborative, that just kind of took this slow and steady pace that we were on and kind of kicked it into high gear. We had already been working on some type of recognition for our EMS and our hospitals, but the PECC Learning Collaborative kind of took the role of the Pediatric Emergency Care Coordinator and made us move things forward a little quicker. So our initial goal was to increase by 10% our HAS PECCs. So at the time, we had about 49 people in facilities that were identifying as had PECCs. So we only needed to meet that goal by adding 5 more PECCs to that. And we did that through a grassroots approach. In the next slide, please. So at the beginning of our PECC collaborative, what we really did is we looked at taking the idea of the HRSA roles and responsibilities and presenting it to a variety of healthcare providers. So that was nurses, EMS providers, doctors. We had all levels of EMS represented. We have medical directors, and we had basic EMTs, and we had just a well-rounded group of participants in that focus group. At that time, we really recreated what we wanted our New Mexico criteria to look like, and we went forward with a pediatric champion, because what we did find was that even though we had people who said that they were pediatric emergency care coordinators, they were voluntold to do that, or they were just had their name put there. So we really had a difficult in finding that empowering passion that our champions who have evolved over the last couple of years that's what we're working on. We're taking that slow and steady pace, and we're really trying to find the passion in people to move this forward. So if we go to the next slide, we can talk about what we've done to help facilitate the things necessary to make the PECCs have passion and give them the resources that they need. So in our process, we developed an online application. So everything had been taken to conferences. We've been going to EMS meetings. We were at our regional trauma advisory council, and we took paper copies, and we took different modes of getting our message across. And we asked people to become a PECC, and then we realized that we needed to have something that we could send out to a broader audience. So we were lucky enough to have some very gifted people working with us. Amy Pottinger, some of our research assistants who are undergraduate students, and we're trying to help inform them of pediatric preparedness as well. They created these online resources for us. So the REDCap survey link now has the ability to not only house our PECC information for our EMSs and our communities, but our facility recognition applications are all online. Our medical director, David Jolly, created some pediatric guidelines and protocols that are available through QR codes, and we can give those to our facilities and our PECCs as resources. We have our clinical resources available, and these are some pictures of our capabilities in a smart spreadsheet that we send the link out to our providers, and they can just link onto the sheet that they need. Included in those, we also have interfacility transfer guidelines, which have our templates in it, some wonderful resources that we've shared or have been shared with us from Kansas and Kentucky. We're trying to make this, whatever mode you need, we're going to get it to you. So we're trying to be responsive to what our PECCs are asking for. And that includes even having some memory sticks available that we can mail out to them. And we appreciate those when we get them, so we thought that would be the same. Next slide, please. But I was talking about earlier about finding people voluntold versus that true pediatric champion. And some of our stories that have been shared with us and things our pediatric champions have come up with. Chad Kim, who is not only a paramedic with Albuquerque Fire Rescue, he's also our Family Advisory Network representative. He will be doing a podcast on medical dosing errors that he's seeing in the field with people who are newer to the field, and some of our medical dosing errors that he sees. He's going to do a podcast that we can use not only with our Albuquerque Fire staff, but we can also disseminate that through our resources. Superior Ambulance is one of our biggest agencies in New Mexico, and they really took on safe transport. So they had their field supervisors actually become technicians, and they are working to share that training in all their areas. They have areas down south, they have areas up north, they have areas all over. So that's getting disseminated well. Our hospital PECCs, we have up in the top part of our state in Raton, we have our first minors Colfax, and they're really looking at becoming pediatric champions in that area and getting recognized so that they have a better understanding of what they can deal with there and what they will have to transfer out. One that I'll talk about more in the next slide is our Zuni Tribal Healthcare Center. And this is Jason Kurland, and he is not only our champion at the hospital, but he was also a community member who got to take advantage of that. So Dr. Kurland is a father of two, and he and his wife are family doctors, and they work in the ER there. And a few months ago, their 3-year-old daughter, their lovely little girl, tripped and hit her ear on a table. So even though he knew it wasn't anything life-threatening, he was worried about how she was going to heal. So he went back to the hospital where they were taking care of it already. And even though they were certain that it wasn't going to be something that had to be transferred out, they went ahead and used our Child Ready telehealth. And that provider consulted with our office in Albuquerque, and they were able to really provide reassurance and clinical education on on how to drain that hematoma and take care of it. So as you can see that what it looked like, and then how she went through and her lovely smile afterwards, that everything worked out wonderful for her. So our pediatric champion got to use the benefits of having our program in their community with a good result. That was just one of my favorite stories to share. Dr. Kurland would love to participate in one of these calls next time, so we'll hope we'll have another opportunity to bring him to talk to you as well. Next slide, please. So our two top challenges, and that's my grandson, because we want to make sure that everybody understands you just have to roll with the punches, and turnover contact information, always difficult because sometimes people are in a role for a short season, sometimes they're in for many seasons, and we just know that's a possibility that we may not get the same person twice at the service. The perceived importance about pediatrics due to low volume, a lot of people were like, well, pediatrics just aren't our focus because we're really looking at our older patient populations. But some of our proudest moments have to do with our big Albuquerque area, Albuquerque Ambulance Services, which actually our pediatric champion there developed the region's first EMS pediatric board, which was outstanding because this was on, she wanted to take it on. She wanted to get the partners involved, and we'll have a first meeting in April. Some of the other things, we're working with hospital pediatric champions who are at our level 3 trauma hospitals in developing rule changes that really, we already had some pediatric components in our trauma designation, but they're bringing them to the forefront and making sure that they are actually mirroring the National Readiness Pediatric Assessment. So we're very excited for those changes coming along. Top 2 lessons learned is if you want it to get done, you have to make sure that you have buy-in from the people who do the work. That is absolutely critical. And then when you have their buy-in, make sure you're friends with their bosses because they're the people that are going to allow them to do the work. Other things are incentives, offering free PECC skills trainings, offering those resources that we discussed, making conferences available to them. So we are very excited to be able to provide that all within our New Mexico EMS for Children and Child Ready programs. And I believe that I'm getting ready to talk about the OG Pediatric Emergency Care Coordinator in New Mexico, and that would be our lovely Sarah Dakin.
Hi everybody, thank you for coming. So as they said, I'm the PECC up in Albuquerque, New Mexico at UNMH. The question a lot of people ask is, how did I become a PECC? And coercion is probably one of the biggest things. Thank you, Dr. Sapien. But there's also a need. And that need is to, really provide the best care for our patients. Sorry, it flicked multiple slides. Let's go back. There we go. Too far. Okay, there we are. Even in large institutions, we do find that sometimes pediatrics are not a focus. They get kind of buried under the influx of adult patients. So it's nice to be able to have someone that is focused on pediatrics and can make it a priority for the department and provide what's needed to get those patients the best possible care. So what do I do as a PECC? Currently, I provide education via telemedicine to a lot of the rural communities, tribal hospitals, the smaller facilities. This really facilitates keeping some of these kids in the community and support the nurses to take care of those patients. And even patients that need transport, it's really nice. They get to see a nurse or a doctor on the television screen before they come up. Family feel a little more confident that where they're going. And the kids actually find it really exciting. They get to see their physician or their nurse before they come up. I provide education to some of these rural nurses. It's a strain on resources, having to travel up to Albuquerque or Santa Fe to get pediatric specific education this way. They can get some pediatric specific education and remain in the community, which is really nice. They get to make it a little more relevant to their practice. They can ask questions in the moment. I'm also part of the disaster planning team specializing in pediatric. Even though we are the level 1, we still have to plan and make sure that PEDS is included in that disaster plan. And hopefully train more nurses so then for such events as COVID, we are prepared and ready to go and include pediatrics in our disaster plan. So what resources do we have? The telehealth cart is a wonderful technology. When I do my education, I can see the whole room. They can interact in the moment. They can ask questions. I have done some more hands-on skills. We've looked at different IVs. The telehealth cart has a camera so that we can look at smaller, look at veins. We can talk about IV starts and things like that. For larger audiences, I've presented at conferences, and the ENA has been very supportive of a lot of these, and I've presented some of this at conferences. One of the resources that would be very nice would be, as everybody has said so far, is more money to really get this up and running and really support what we're already doing. How do I balance things? That's a big one. So one of the nice things is several of our facilities that have asked for education. We have a set time, so it's really nice to organize my schedule and make sure that I can balance different duties. But the telehealth time, 7 a.m., Mescalero, I attend their staff meetings once a month. They've incorporated it into their day. I've incorporated it into mine, and it works really well. I enjoy talking to them, and then they can ask me specific things to their area. What's going on at that time. We all have more regional problems going on at specific times. They were having a lot of fires, so end of last summer, and they would ask me to do education specifically to respiratory distress at a time that the rest of the state was really not having much of a problem with respiratory issues. And so my work activities, telehealth, the monthly training like we talked about. I've also done in-hospital specific training. I've traveled to a couple of different facilities and done hands-on training on an area that they are specifically concerned about. Quite often this is stabilization of trauma or IV starts, things like that, because those are definitely high stress situations, but there also tends to be low volume. So when they've had an event and they're feeling a little unsure of how they've performed, it's really nice to get that feedback that everything went well. I can also do chart reviews with patients that have been sent up to Albuquerque for us to be seen. Again, a lot of these smaller facilities like some feedback as to, did they do okay? So it's really nice to be able to give that feedback, how things went, if there was anything that could have been improved. But the biggest part is giving that reassurance that they did well. Sorry, that was me. So far with the telehealth, Child Ready Telehealth program, we have 13 different facilities. We have done 93 consults. And the nicest part is 75% of these patients have stayed in the community, saving New Mexico $2.46 million in transport dollars. And that doesn't even take into consideration the fact that families are going to have to stay with the patient. They're going to have to incur costs. not being able to go to work, things like that. So this role has really helped facilitate these patients in the community. And I'm very proud of the fact that we've managed to support so many patients staying in the community and getting excellent care in some of these smaller facilities. So tips, two of the biggest challenges for being a PECC, let's say, definitely engaging staff in education or rollout of new equipment. Often, especially with new equipment and education, if it's not relevant to that moment, people are not vested and they're not interested. So trying to keep the education relevant to what they're seeing at that time and keeping it relevant to the in-the-moment experience. So, for example, I do respiratory care education in January and December because that is what they're seeing the most, and it really does get a little more buy-in. In June, nobody's interested in respiratory care. A lot of broken bones and things like that. So that aspect of the education, keeping it relevant. Getting pediatric specific equipment for some of the facilities due to budget constraints can be hard, because if I sit there and say, oh, you need the latest and greatest pieces of equipment, which they're going to use maybe once a year, budget constraints are not going to be available to buy the equipment. So I have to get creative when I'm making suggestions, asking what is currently available and making sure that what I'm educating them on is something that they can achieve. So my two tips, others in the room, is be enthusiastic. They don't want to see somebody just standing there on the other end of the screen. I have to be at 7 in the morning. I have to be engaged and bouncy and enthusiastic about what I'm teaching them, and try and teach in a creative manner, not just droning on and on about something that they're not interested in. Asking questions and trying to keep it engaging. And back to what I was saying, picking an appropriate time to implement new tools and procedures. You guys are all in healthcare, and I'm sure right now if I came to you and said that I was rolling out some new IV start kits with everything going on with COVID, that you would not be interested in hearing what I have to say, and you would just walk away. So ensuring that when you are implementing new things, that it has a relevance and it's a good time for the staff and the PECCs to be doing that. Nobody wants to hear things about pediatrics if they're not going to be using it currently. And two tips. Oh, that was not me. I wasn't even touching my computer. Okay, hang on. Trying to go back, sorry. Okay, two tips for how to get others involved. I think explaining that how having a PECC in your community or your facility or wherever the role is how it's going to impact your family and the flow of the department, and also how it impacts the community. Like I said on the previous slide, we have kept so many children in the community, and we can all see the benefit of keeping the patient in our community if it's safe and we can provide the best care. And that's basically what a PECC can do, is ensure that the community has the resources and the knowledge and the availability to provide our pediatric patients with the best possible care. And that, I think that is the biggest part for getting PECCs and getting the community involved and behind any changes and improvements that the PECC may want to do. And thank you for listening. I think it's Wisconsin that is next.
Yes, thank you, Sarah. And we are running a little bit over. So this is being recorded and it will be on the website, and we'll also be sending out the link to the recording. So if you have to jump off, you'll be able to listen to this later. I'll go ahead and give an introduction for Erica and Jill. Joel. Erica Kane is the project manager for the Wisconsin Emergency Medical Services for Children State Partnership Program. In this role, Erica works with partners throughout the state to improve emergency pediatric care in pre-hospital and hospital settings. Erica has over 10 years of public health experience and previously coordinated community-based injury prevention activities for a level 2 trauma center in Wisconsin. Erica received her bachelor's degree in community health education from the University of Wisconsin and a master's degree in public health from the University of Wisconsin-Madison. And Joel is a paramedic with 10 years of EMS experience. He is a deputy chief at Steinsville Fire Department, where he also serves as the pediatric emergency care coordinator. He has a passion for pediatric emergency care and is a certified child passenger safety technician. And Erica, I will be giving you the controls here.
Okay, great. Can you hear me okay?
Yes, we can hear you.
Okay, great. So Wisconsin is a mix of urban and rural. We have a population of 6 million, and about 20% of that is pediatric. And each year we produce 2 billion pounds of cheese. Wisconsin has 735 EMS agencies, and for this collaborative, we developed a 12-member core team that was made up of advisory committee members and several new EMS partners. And we first convened with an in-person meeting in March of 2019 and provided regular updates to our core team thereafter. Just
if you need me, I can
having a little
advance the
trouble.
There you go.
I might need you to. Oh, thank you. Okay, thanks. So as of the start of the collaborative, we had 66 PECCs, and by March 2019, we had 73 PECCs, and as of March 23rd, when I turned in these slides, we had a total of 105 PECCs, and even since then, we've recruited about 18 more. For our recruitment strategies, one of our major recruitment strategy was identifying a pediatric emergency care coordinator, program manager, Jason Solwichka, who worked under a contract with us throughout the project. We also developed our PECC stakeholder group, like I mentioned, and Jason worked to recruit PECCs at all of the major EMS conferences in our state. He attended regional and county EMS meetings, and really any chance he was able to get out in the community and spread the word about PECCs, he was able to. And I think it was super helpful having a contractor who is so well connected in our state, and it really just gave a lot of credibility to the program and was definitely the most successful strategy we used, and I think such a great decision to go that route. Because we had the supplemental funding, we were also able to initially offer a $500 stipend to target agencies that agreed to add a PECC during the Learning Collaborative. And we also, as a recruitment strategy, prioritized agencies that had PECCs for any in-person training opportunities that we offered. Some of our deliverables, we developed a paper-based PECC commitment form, and I have a screenshot of it here. We also developed a stipend application and a tracking system to keep track of our stipends we distributed. We also developed an online PECC toolkit, and we continue to make that toolkit even more robust and offer more resources. The toolkit includes an interactive map, and then we also created a web-based PECC form. So if you have that ability at all in your states, I think Catherine mentioned it as well, to create something web-based for tracking your enrollments in the program. It just really helped us be a lot more organized, especially now as it's really picking up, and we're seeing that when we log into our email every day, we have even more PECCs coming through. We also offer quarterly virtual meetings for our PECCs. Something we developed recently was a PECC press release, and I believe that's going to be available to anyone that wants to use it on the EIIC website. And that press release can be used and modified by PECCs just as a way to highlight their local efforts, give some recognition to the agency, and maybe create some friendly competition amongst other agencies in their communities to get on board and have a PECC. We also developed a challenge cling program. We developed PECC window clings, and we'll be offering those to our PECC agencies. We had planned an in-person meeting for our PECCs on the 18th and the 19th of this month, but that had to be rescheduled, and we'll look to do that in the future once we get past all this. Some of our stories from EMSC, I think one of the really cool things we've been able to do with our PECCs is offer a way to partner and utilize existing trainings in our state. So we've offered our PECCs an opportunity to become trained in the Impact Teen Drivers program, where they can utilize that training to offer distracted driver prevention training in their own communities. We also offered training to our PECCs on safe sleep and an opportunity to distribute baby boxes, which are featured in the flyer that you see on the screen. They're actually a cardboard box that has a sturdy mattress and offers a safe sleeping environment for infants in situations where it otherwise would not be available. We've also been able to partner with child life specialists from one of the children's hospitals in Wisconsin to provide trainings for PECCs virtually on how to communicate with children and different tips for working with kids that have autism or are nonverbal or have other special healthcare needs. And we've been able to partner with the Infant Death Center, which is also housed within Children's Health Alliance of Wisconsin, to offer a training called Grief 101 that gives support to EMS providers who are working with a parent that's recently experienced a loss. This is an example of something else we were able to create on our website. Our communications coordinator at the Children's Health Alliance of Wisconsin was able to do a formal interview with one of our PECCs, Armando, go out and take some pictures at his departments and publish a news story on our website. And it was the most popular page on our website in February. So that was a great way to get the word out about PECCs. And as far as our top twos, so the rest of the EMSC program managers on the call might relate to this, but in Wisconsin, we used a random sample for our original performance measure survey back in 2017, 2018, and that made it really hard for us to identify target agencies, since not every agency in Wisconsin had the opportunity to be asked if they had a PECC and if they had interest in adding a PECC. So that's something we're obviously doing different this time around. Also, just of course, the short timeline that we had with the funding, and we had delays with getting contracts with our state health department, and then delays internally at my organization with being able to get Jason's contract in place. Two of our proud moments recently, I think we've had a lot of proud moments with this collaborative, but two recent proud moments where Jason Sowichka was able to work with our state licensing program to get an optional PECC field integrated, so that when agencies complete their relicensure, they're able to indicate who the PECC is at their agency. So it's just going to give so much more visibility to the PECC role. And recently, we recruited our 100th PECC, and that was just exciting because it feels like such a big, solid number, and we're just excited to keep seeing this grow. Two lessons learned and tips for others. The stipends were helpful, and of course, we wouldn't be able to offer those without the supplemental funding we had, but only 50% of the agencies that we recruited during the period of the supplemental funding actually requested a stipend. So it wasn't something that, was required to get an agency to sign up. And we've recruited many, many more agencies since the supplemental funding was over without the offer of a stipend. So it's still rolling. And then our big lesson learned and our priority right now is to continue to develop PECC tools and resources. I think we're really focused, like everybody, on we don't want to just sign up people in name only. We want to make sure that all of our PECCs have the tools and the resources they need to do their job as PECCs. And I know one of the questions that came through on the chat box was wondering about, like, on the list of the job descriptions that we get from HRSA, it's, ensure availability of pediatric equipment. Like, how do we work with all of these ensure job descriptions? They all start with ensure, I think. And something we've kind of said is, like, we don't expect a PECC when they first start to do all of those things. They're all examples of some of the roles that they might end up taking on. But as an EMSC program, we want to make sure that for each one of those job description items, there's a tool or a reference that they can go to help them meet that need at their agency. Okay, and Joel Deutsch, one of our local PECCs, agreed to do a short presentation and talk about his role as a PECC, but I'm not sure if he's on. He was on shift today and he was on a call right before this. I don't know if Margot, if you can tell if Joel's called in at all.
Yeah, I can check real quick. It does not look like he has.
Okay, well, I'll do my best to cover and speak on his behalf. I know we're both willing to take questions offline after this call. So Joel first got involved in the PECC initiative and with pediatrics in general because he became a child passenger safety technician. That's actually where we first met at one of our technician courses. And as a PECC, he's been working to ensure the equipment, the protocols, and treatments are appropriate for pediatric patients in their departments. And the resources that they've primarily been using are the toolbox on the website. So I think he's referring to the EMS Wisconsin EMS for Children website, and then time. And I think time is really, since this is an additional hat he's wearing, that the time piece is key. So as far as how other agencies think about his role, he's doing a lot of the work behind the scenes. So in some cases, they're not aware of what he's up to. And he's working on balancing the PECC initiative as time permits, balancing all of the other responsibilities he has at the department. So two examples of his work as a PECC, becoming, of course, more active in pediatric care. And something Joel's become a big advocate for is working on safe transport of pediatrics in ambulances. So he's actually been working with the Wisconsin EMS for Children program on an ad hoc committee and working on developing a handout that we can distribute to all the PECCs on this topic. Two of the biggest challenges are finding time to dedicate to the PECC tasks and really navigating through all of the information on implementing this role. Two of his tips to help others would be to utilize resources available and to network with other PECCs. And two tips on how to get others involved would be, the big one would be to use the resources on the Wisconsin EMS for Children website. So we're really happy that that's been helpful because we've put a lot of time into compiling those resources. Thank you.
Thank you so much. Now, if anyone has any questions or discussion points, feel free. I'm going to also look in the chat box to see what else has been shared during the presentation.
I appreciate the overtime. This is Mark. I really want to thank our presenters and our attendees as well for all the work that you're doing. And we're here for each other during this really challenging time. And you know, for an hour and 15 minutes, maybe a little distraction from some of the challenges with WebEx, but we really learned a lot from our wonderful presenters and hope that continue to learn from and with each other. We'd like to remind you that this was recorded. There are a tremendous number of resources that many of our states have shared on the EIIC website, but I can speak for the community of practice sort of evolving. The Learning Collaborative quite frequently borrowed very aggressively from each other with things such as the education and training materials, the sign-up sheets, and many other aspects of that project. So the coins are something that I'm not as familiar with, but I think that's a really cool idea, and saw some chats on that as well. Were there any other questions that we're missing? I know we are a bit over time, and again, really appreciate everyone joining. All right, I think with that, we'll let everyone get back to their care. I have some kids jumping in the background that just finished watching a movie that they were assigned to for this time period. So thanks so much, and everyone be well, be safe, and we're thinking about you, and healthy. If you're not healthy, we're thinking about you and praying for you. Take care. Bye-bye. One second, okay?
We could watch something else?
No.
Why?
We're not watching anything else.
Well, you said we could watch something else.
I said if I had to stay on the phone.
Well, you said...
Okay.